Why do carers of patients using non-invasive ventilation need to learn rescue breathing? They need to learn how to perform rescue breathing so that if the ventilator fails at a moment when the patient requires assisted breathing, the carer or family member can support the breathing of the patient. Is rescue breathing a necessary skill for carers or patients who only use nocturnal ventilation? If patients are only using nocturnal positive airway pressure for sleep apnea, rescue breathing is not necessary. However, especially in patients with neuromuscular weakness, even if in good times they are using NIV only at night, when they have a respiratory infection, they may end up using non-invasive ventilation round the clock. As such, if the ventilator were to fail them during either day or night time, it is imperative that the family member or caregiver knows how to perform rescue breathing. Isn't the traditional bag and mask method of rescue breathing good enough? The traditional bag and mask method requires the use of an air cushion mask together with chin lift and jaw thrust by the rescuer using either one hand or two hands, and the squeezing of the self-inflating bag either by the same rescuer or a different rescuer. This method is very effective in CPR situations. However, it is very tiring for the rescuer and it is very uncomfortable for a conscious patient. As such, we teach rescue breathing, especially for the context of ventilator failure, using an alternative method which is easier on the rescuer and more comfortable for the patient. In the case of unconscious patients, the tongue may flop back and the upper airway may close because of further loss of muscle tone. As such, for unconscious patients, it is safer to do traditional bag and mask with emphasis on good seal as well as a chin lift or jaw thrust. Can't we just give the patient supplemental oxygen from the concentrator or the oxygen cylinder if the ventilator breaks down? The answer is no, especially if the patient has neuromuscular weakness which leads to carbon dioxide retention. Asking the patient to breathe on his own, air enriched with oxygen, would greatly increase the risk of high carbon dioxide levels in the blood, or what we call type 2 respiratory failure. This can lead to loss of consciousness and even death. What do you need to do before home discharge? As most non-invasive ventilator interfaces come with a length of breathing circuit, which may be long or short, it is necessary for you to ask the respiratory therapist or the respiratory nurse to discuss with the vendor and work out a way to use a short length of corrugated tubing to connect directly with the non-invasive ventilator interface, which could be the mask or the cushion. You should do this before the patient is discharged, and once the arrangement is fixed, You should take a photograph and carefully label the tubing, and you should practice this at least once a week so you know how to assemble the circuit in the event of an emergency. What practical advice would help to ensure success in rescue breathing? The first point is to practice frequently. You should take out the circuit, assemble it, and practice rescue breathing on your loved one at least once a week. The second is to match the respiratory rate that you deliver with the patient's comfortable rate, which usually is what is set on the ventilator. For example, if the ventilator rate is 15 breaths per minute, each breath would be 4 seconds, and usually the inspiration or breathing in period will be shorter than the expiration or breathing out. You can count aloud, for example, in to 1000, 3, 1000, 4, 1000. Or you can use another way of counting like in, 1, 2, 3. Whatever it is, you should mentally note and then ask the patient whether this is too fast or too slow. Do note that when you do rescue breathing with the patient's NIV interface, there will be areas where the air leaks. This is called intentional leakage in the NIV system. As such, it is often necessary to use a two-hand method, squeezing the self-inflating bag with both hands. Again, look at the patient and ask whether each breath is too big or too small, and whether the breathing in time, the inspiratory time is too short or too long. So with this feedback that you receive during your weekly practices, you'll be more confident to deliver successful rescue breathing in the event of a real ventilator breakdown.